It's routine for a doctor or care provider to write up notes during and after a patient visit. Generally, the notes are a running record meant for internal use and aren't typically shared with patients. But that is starting to change, both in America and internationally. And guess what? Patients like this increased access. Welcome to Advancing Health, a podcast brought to you by the American Hospital Association. I'm Tom Hedderly, senior writer with AHA. Ever heard of OpenNotes? It's a movement to make healthcare more transparent. That means inviting patients to see those notes that were written up during and after their visit with their care providers and helping them to understand what they're reading. The OpenNotes approach has been around a long time, but there is renewed interest in the idea today as patients signal their interest in playing a larger role in their own healthcare decisions. What do patients and providers have to gain by shared access to these health records? And are there any potential downsides to this increased transparency? Brian Granulotti, AHA Board Chair and President and CEO of Atlantic Health System, discussed these questions during a panel discussion with leaders from OpenNotes held in July as part of an AHA Executive Forum in Boston. Brian's three guests were Catherine DeRoche, Executive Director of OpenNotes with the Beth Israel Deaconess Medical Center, Liz Salmi, Senior Strategist for Outreach and Communications, also with OpenNotes at Beth Israel, and Dr. Rasu Shrestha, Chief Strategy Officer and Executive Vice President with Atrium Health. And now to Boston, where Brian kicked off the discussion.
So let me give a little setup on this. I think we've all participated in medical care. Has anybody not ever been to a doctor in the room? So most of us probably don't remember what was said to us because we filter it, right? If it's good, oh, everything's fine. Then you miss the part about you got to lose 5 pounds, or, you miss that part. Or if something's really bad, you hear something's really bad, and then you kind of blank out at that point. And today's discussion really focuses on that and really says, how can we really stay connected to the experience and the information that's exchanged in the exam room? And I think we all know, particularly those of us who have been on this journey through academic medicine, how sometimes that's a difficult topic to get our faculty or physicians' heads around, is how do you put this patient in the center of that kind of a conversation and empower the patient? So we're joined by 3 really great people here today, and you all didn't have to travel that far. Well, you did. But you may not get back. My flight was just canceled.
Oh, no.
So
so good luck.
I have to kill your presentation today. Catherine DeRoche is the Executive Director of OpenNotes at BI Deaconess here in Boston. Liz, you are a Senior Strategist of Outreach and Communications at OpenNotes, Beth Israel, but you got an interesting story about being a patient.
Yep.
And that was really compelling, that whole conversation. And thanks for your sharing it, and thanks for getting engaged on this. And I'm sure others will feel that way. And Dr. Rasu Shrestha is from Atrium, and you're the Chief Medical Officer and EVP, and you've got a lot of experience with this also. So we're going to jump right into the discussion. Open things up for Q&A at the end. We got that little timer there, so that'll keep us on track. But let's start with, what is OpenNotes and how did it begin?
So I'll start. So OpenNotes is, I'll first start by just saying what OpenNotes is not. So we're not a software vendor. We are not an EHR vendor. We don't have a collection of notes in a server somewhere. We are a foundation-funded initiative that's grounded in research, and our work is focused on improving transparency in healthcare, and we specifically focus on encouraging clinicians to share the notes that they write with the patients that they care for and assessing the effects of that. And OpenNotes started as a pilot project. So in 2010, one of our co-founders, Tom Del Banco, He strong-armed, sweet-talked, persuaded nicely people to volunteer, primary care docs to volunteer to share their notes with their patients for 1 year. And it happened at the BI Deaconess here, at Harborview Hospital, which is a safety net hospital out in Seattle, and Geisinger, which is an integrated delivery system in Pennsylvania. So they turned it on. They just turned it on for 20,000 patients, and they studied what happened over the year. And in that time, clinicians went from being really, really worried. This is a terrible idea. My patients are going to be constantly emailing me or calling me. They're going to be upset. They're going to be mad about what I write in the notes. I hate this idea, to saying things like, are you sure that this is turned on, because I'm not hearing anything about it? And patients, once they understood the idea, they understood what it was, 80% of the patients who were enrolled in the pilot read at least one note over the course of the year, and 99% of them said, I really think this is a great idea, and I really want this. And a good proportion of them also said this would make a difference to me if I was thinking about a new provider. And then after the pilot ended, clinicians were given the opportunity to turn off patients' access to their notes, and none of them did. So the findings were published in the Annals of Internal Medicine, and since that time, the number of organizations that are sharing notes with patients grew from these 3 with the 100 primary care clinicians to over 200. We're in every state now in the country. Alabama was our last holdout, and we got a place in Alabama last year, and the entire VA. So by our count, we think there are about 40 million patients who are signed up on a portal somewhere where they're offered access to their notes. So that's the 2-minute story of how OpenNotes started, how we got here.
So Liz, you're one of those patients.
Yeah, kind of.
Sort of.
Yeah. Well, to expand on what Kate said, she said 200. I mean, 200 health systems, hospitals, and organizations who've decided we believe in this research and the outcomes, and that patients benefit by reading their clinical notes. Let's share through existing online patient portals.
Right.
So it's not like you have to buy new technology.
Right.
We create no technology. So whether you're using Epic or Cerner or Allscripts, you can push forward your doctor's notes to patient portals. How I got involved, so you mentioned my title. One of my roles is to help translate to hospitals and health systems this changing nature of patient-clinician communication in the age of technology, and regular people having access to more information than ever before. I think Google put out some information that there's 70,000 health-related searches on Google every minute. So people are clearly curious and interested. And if any of you have a health question, you probably look something up online before you call or email your doctor. So people are already engaged in this way, and we can't stop that, and I don't think we should stop that. It's maybe we could be making sure people are making more informed decisions when they start that search. And how I got involved, so my background is actually in communications and design. It wasn't healthcare. And almost 11 years ago now to the day, I suffered a grand mal seizure. I landed in the ED and had a scan of my brain. And then 9 hours later, after a surgery, I learned I have an astrocytoma, which is a slow-growing but malignant brain tumor. It has a high rate of recurrence. And then about 6 months later, that tumor grew back, and it sent me into this whirlwind of treatments over the next 2 years, including a second brain surgery, relearning how to walk and balance, more seizures, and then 24 months of chemotherapy. Now, my background is not in healthcare, but how I was able to navigate my own care was I was really obsessed with those online patient portals my health system had, and I was with Kaiser at the time, and they were really great. I used that portal to email my doctor, make appointments, order prescription refills, and if they'll look at lab results. And anytime I saw a new result come through, I was obsessed. I was like, oh, I want to check this out. What does this mean? And if there are words and phrases in those results I couldn't understand, I would go online to look those words up. And if I couldn't find what I was looking for, I would use that same portal to email my doctor a question. Because what meaningful use is that information without some sort of interpretation? And many years later, a couple of years later, actually, maybe 2.5 years ago or so, before I even learned about OpenNotes, my husband got a great new job, and it forced us to switch health plans. We couldn't continue with Kaiser. So I thought, you know what, I know my care really well. I got to find a whole new team of doctors, but I know my way around healthcare. That'll be so easy. I'll pick this whole new team of folks who will care for me, and I'll just get all my records and easily transfer them to where I need to go. And I had no idea that real simple request for my records was actually going to be really complicated. It takes time and effort, and there are many costs involved. Had I asked for a paper copy of my record, it was going to be over $700 for a paper copy of my record, because my record, I learned later, was 4,839 pages of a PDF file. Instead, I paid for a digital copy of my record on 3 DVDs, 2 discs of just imaging, and 1 was the PDF of my medical record. And as a curious person who just spent $45 on something I didn't really understand what it was, I stuck one of the discs in my computer, and I found that PDF file and started scrolling through page by page this record. And as a person who felt like I really understood my care and was already using this patient portal, I was really surprised at the number of things in my record that I had never seen before. So some of the stuff was emails back and forth with my doctor, which I had seen, or those lab results. But the majority of our record are our doctor's notes. And I had never seen these things before. And our notes, as many of you know, are the most important information in our record. They're there to remind doctors and other members of the healthcare team about a person's condition and plan for treatment. But as a person living with a condition, I had never seen these things before. And it was eye-opening and cool and interesting. And it showed me that my doctors were really listening to me. And they reminded me of things I missed when I was unconscious from surgeries and seizures, or freaked out, or things that my husband and I couldn't remember because we were both so worried. Thank you, whomever pulled up this slide. This is a side-by-side I like to share of what a person sees. Most people just have access to something called an after-visit summary in their patient portal. And what you get is how much you weighed, how tall you are, here's your resting heart rate, stuff I can figure out on my own at home. And then, meanwhile, here's just a piece of one of my notes, maybe just about a third of it. And there's so much more information in here, and that assessment and plan for care are the details that I need when I go home. And what I love about, and I actually don't have access to my notes, a la what the OpenNotes movement is all about. I have to request these things after every visit. But what I love about this is when I'm going back to the doctor and I'm trying to remember what are the questions I need to have for her, I can refer to this to go, what did we talk about last time? Okay, what do I need to ask her about this time? And so it's really helpful. So we could talk more about the research, but that is what inspired me to want to get more involved in this research project and try to hopefully change some culture in medicine to open the notes to patients so we can make better decisions because we better understand our care.
From your perspective, what do you think?
Absolutely. So I'm going to try to bring a slightly different perspective to the discussion today. Rasu Shrestha, I'm a radiologist by background. I've been in health IT and informatics now for the last 20 years or so. 5 months ago was when I moved from Pittsburgh to Charlotte, North Carolina. So I was with UPMC for the last 12 years, and my last role as the Chief Innovation Officer. And I'm charged with strategy at Atrium Health, which is the Carolinas healthcare system. So about 50 hospitals in North, South Carolina, and now in Georgia as well. When I was at UPMC, real strong advocate of OpenNotes, and refreshingly so as I was contemplating moving to sunnier weather in Charlotte, where we would not have a block of ice in a swimming pool in the backyard if we had one. And so I was thinking, look, I wonder what the status is for OpenNotes at Atrium Health. And really pleased, this is before I even decided to pull the trigger, to understand that Atrium Health had been an early adopter of OpenNotes, and we've actually been live with OpenNotes since September of 2015. So we've been up and running for a while. And what's really interesting is, and I've learned more of this in the last several months that I've been there, that the adoption rate, to your point, of how it's being embraced by the physicians. I wanted to bring that perspective of the provider and the health system, and how is it really on the ground, right? So how it's been embraced by the physician community, the provider community, as well as the patients that we're serving, the communities that we're serving, has been mind-blowing. Clearly, right at the beginning, there was a lot of apprehension. Oh my goodness, all of those things that I write in the EMR, you're telling me that we're now going to expose it to the patients? Right? Because we're in the United States, and I can say this as a physician, we're really aware of sort of the trigger-happy society that we are in terms of lawsuits. So it's defensive medicine is what we really practice in the United States. And so, there was a lot of apprehension, but the embrace has been tremendous. And the resulting sort of leaning forward of the patients and the conversations, this movement to humanize healthcare, right? So it's not just about documentation and coding and billing, which is really, if you think about it, what the EMR systems were built to do, versus the reason I went to med school was to actually make a difference in the life of a human being, to cure an illness, to have a conversation, to empathize. Those are attributes that aren't typically captured in sort of the stoic nature of how EMRs are built today. And in this big digital wall that we erect between the patient and us, the providers, it doesn't help either. So the OpenNotes movement really is there to sort of crack that wall, to break that wall down. I talk about how the best disinfectant really is sunlight. It really is. And it's the same thing for our electronic health record systems as well. There's so much data. We're data rich and information poor. So I'm a radiologist by background, and we're always, playing the role of a detective. We're trying to piece information together, and we compose our radiology reports, which may or may not end up in the hands of our patients in the manner that we want. But with OpenNotes, we know that it will. We know that if I have the eyeballs of the patients and perhaps their loved ones on those notes, what we have suddenly is an uptick in the accuracy of the documents, in the engagement of the patients, in the empowerment of the patients and their circle of trust in the care that we're providing to them. Right? And we see a reciprocal uptick in the quality as well as the outcomes of the patients that we're serving. So a couple of quick numbers. So I mentioned we went live in 2015, so it was September 1st of 2015. We were the first healthcare organizations in the Southeast to release notes as part of the OpenNotes movement. We have, if you're curious, we have inpatient notes, ED notes, urgent care, variety of outpatient notes. It's only the behavioral health notes in large parts that we've contained. It's really amazing. I mentioned sort of the uptick and the embrace of the OpenNotes movement amongst the physician community. And one of the things that we're contemplating right now is sort of the demand from our behavioral health physicians who are coming to us and saying, open my notes up too. It's amazing. A couple of more numbers. Over 100,000 documents per month that are either viewed or downloaded through our portals. 100,000 documents. 90% of My Atrium Health users, so this is sort of our portal, 90% of the My Atrium Health users access the OpenNotes landing page. So it's not 9% or 20%, it's 90%. So the numbers are really through the roof, and the embrace has been absolutely tremendous. So just wanted to make sure that you understand that this is real. We can get a little deeper into some of the cultural elements of this, some of the challenges, as well as sort of what's coming from a health provider system. But I just wanted to at least kick things off by letting you know that the OpenNotes movement is real.
That's a fascinating thing you just said about the number and uptake, because I know in many of our organizations, when we talk to our marketing folks, what they're trying to do, particularly on digital platforms, is get eyeballs, right? And there's always this dilemma about how do you get people to do that. It sounds like this is one of the tricks to be able to do that, is that it will direct people towards digital platforms that you can interact with patients on from a variety of ways. Is that part of the conversation that occurs when you're trying to get hospitals to adopt this?
So we have heard from different hospital systems that when they open up the notes and they actually socialize the patients to the idea that the notes are there, that they do see an increase in the proportion of their patients that register on the portal. So it doesn't happen all by itself. The other thing that we've learned is you can't just turn it on and check the box and say, yes, we did it, because it's an educational process for both patients and providers. You know, you have to, there's a lot of work around the culture change for providers, around what might happen and their worries, and sort of soothing. There's a lot of soothing that has to happen. But for patients, most of them don't even know that you write notes, let alone that they could read them and why they should read them. So there are some steps that have to happen in between that. We turned it on, and now 90% of our portal registrants are looking at their notes. So there's work that has to happen in between.
We've socialized patients. I feel weird talking about patients. I am a patient. We've socialized us that all you see is this thing, this after visit summary. So most patients don't know notes are being written, that there's all these details there.
Right.
And as part of our work, we talk to a lot of health systems who are like, okay, we want to start opening the notes. How do we do this? And we encourage them to let patients know the notes are there. And we're starting to hear about best practices of how do you do this outreach and communication when you're ready to start showing the notes are there. And some organizations who are really embracing this use the notes almost as a carrot to drive up portal registration rates and use of the portal. They want more of patients using the email system so they can email their doctor as opposed to always calling. And then when they say, hey, there's all this cool stuff there are the notes there, you can read the transcript almost of today's visit, it gets people on. And there are organizations who put this, when you log into the portal, what is the first thing people see? If there's a read your new note button, people are excited about that. So if you're trying to figure out ways to get more people on your portal, this is one way you might do that.
Now, at Atrium, it still is predominantly a privately practicing community, although it's going through that change.
Sure.
What's that conversation like?
Yeah, no, that's a great question. So UPMC was a different beast altogether. So UPMC, really a payer-provider, a payvider organization with over 40 hospitals. On the payer side, much like Geisinger, and you referenced Geisinger earlier, and Kaiser, where you're still struggling through sort of getting access to the notes. At UPMC, it was 3.5 million members, lives covered. So it was really interesting, the dynamics there. At Atrium Health.
And Atrium's more like most of the organizations in the country.
Absolutely. So as much as we talk about value-based healthcare and UPMC and other IDNs, payvider organizations talk a lot about this, and we are as well. The reality is that much of healthcare, as you're pointing out, is still in the fee-for-service environment. And sort of that's the reality of the environment that we live in, and Atrium Health is representative of that. One of the unique attributes of Atrium Health, which I think is, again, just sort of a front to what's happening in healthcare across the board, is that we pay an undue level of emphasis on what's happening in the community, what's happening to the patient, who is really also the consumer. So healthcare is a lot more than just sort of where we have the bricks and mortar facilities, and we talked about this in the earlier sessions today as well, is how do we take it to where consumers eat, work, live, and play. And that's a level of emphasis that Atrium Health really brings to the table. So two things here. So one is sort of the patient/consumer angle, and then the other is the provider or the physician angle. You referenced South by Southwest earlier. As I was dressing up this morning, I was contemplating, should I wear my South by Southwest t-shirt? I had the Fight Burnout t-shirt under my sports jacket at South by Southwest. And I think we're all dressed a little differently for the
No, I have on the same outfit.
Do you have the same thing?
Different shoes.
You had more of your tattoos exposed.
Yeah.
Punk rocker. So really, Liz is the rock star, by the way. So
An actual rock star.
An actual rock star. So this was not the first South by for Liz. In fact, the first South by for you was when you were actually part of a punk rock band.
Yeah, that's right.
Bit of a backstory there. So talking about rock stars in healthcare. But So we're thinking, look, from the perspective of Atrium Health, what does it mean for the patient, and what does it mean for the physician? And amidst this pushback you normally get when you're saying, I'm going to turn the notes on so that the patients can see this, and we were having this conversation earlier, a lot of the physicians are like, oh my goodness, I already have so much work to do. Now I have to handle this flood of calls and inquiries from patients, and I'm already so burned out, I'm going to get burned out even more. What we're finding, and this is my personal passion in this, what we're finding is that when you're able to humanize the care process by opening those notes up, what we're seeing is that the open notes then becomes a substrate for us to actually have meaningful conversations. So you take on meaningful use. It is the substrate for us to actually have those meaningful conversations, to have the right dialogue, to really say, look, here's what it means for you when we say X, Y, and Z. So we're actually educating our patients. We're not just turning it on, to your point earlier. And here's some specific things that we're doing. We're saying, look, you can, through this thing that we've turned on, actually read through your notes, and you can message your doctors directly. You can look at specific resources that we've also pushed alongside these open notes and find out what it means. So common abbreviations, we love to use acronyms and abbreviations in our notes, but it's important for the patients to understand what it actually means. And then educational videos and materials that we're pushing to our patients as well, addressing their specific concerns about privacy and security, but also letting them know that if they so choose and so desire, they can actually share those notes with their spouses, with their kids, or with their parents, with their loved ones. Because that's important for them to know that they can do that. Not just to understand that there is a note, oh my goodness, and oh, I have access to it, but you can also actually share. So this movement, this cultural movement that we're talking about in the industry is one where we're starting to see the shift from how healthcare has been practiced, not just in the last 30, 40 years that we've been rolling EMRs out, but for really centuries at a time. It's been very paternalistic, right? Paternalistic practice of medicine to more now of a participatory practice to medicine. And I think OpenNotes really enables that level of a culture shift in moving towards more participatory practice to medicine.
Great comments. So we have about 16 minutes left, and speaking of open, why don't we open this to the floor?
Great.
So I'd ask you to try to speak into your mic. You may hear me repeat your question, but please engage now, because this is a great opportunity to ask some questions to some people who really understand this.
So first of all, thank you for sharing of your time and knowledge. It's definitely opened up a lot of questions. One of them being the feedback loop that's created. You mentioned the texting, perhaps the calling, the emailing. Is there a vision too, or thoughts about either direct editing or side-by-side editing of the patient-provided information? And what are the trends? And ooh, we got tinglies. All right.
So we have a pilot that we're working on now at 4 sites. So the BI is one, and then 3 other sites, where we're inviting patients to actually write a portion of the note before a visit. So they get an email, it asks them to log in, they write the subjective portion of the note. So how have I been doing, how am I feeling, what's happened since the last visit, and then they can also set the agenda for the visit. So here are the 3 things that I want to talk about before I come. And so we're doing it in primary care. And it's been interesting so far. I mean, we're still in the data collection phase, so I don't have findings. I mean, I have we have monthly calls with our sites, so we hear stories about things like a UTI that was diagnosed before the patient even got into the room because of what they wrote in the subjective portion of the note, or an interaction between a clinician and a patient where the clinician was able to get that patient hooked in to some mental health care that he needed, because he presented that as, I've got these 4 physical health things I need to talk about, but also this bad thing just happened to me, and I need help dealing with that. So we have some sort of juicy anecdotes about how this new kind of co-production of notes is enhancing conversations between patients and providers. And then I'll tell you briefly about one other project we've been working on related to safety, where patients are asked to read the note, and then they're invited to provide comments back on the note, and it routes through our patient experience office. But they're really good the patients are really good at identifying when there's a mistake in the note and when that mistake is important enough that they need someone to fix it, rather than a mistake that just, the name is wrong. But they're identifying serious mistakes, like the wrong person's notes. I got the wrong person's notes. My note is based on the wrong lab results. My note says I'm not BRAC1, but I actually am. So really there's both the co-production, I think, is just interesting in enhancing conversations, but there's also this real safety benefit that comes, because really, who is more invested in making sure their information is correct than the patient? And that's 2 eyes on one chart as opposed to the clinician, which is 2 eyes on however many she has in her panel.
So the My Notes movement is giving birth to the Our Notes
to
movement,
the Our
right?
Notes.
So that's sort of the official.
We call it Our Notes, but it's really a co-production idea.
Great. It's an interesting question, because I do think, just from a strategy perspective, because I'm the strategy guy, if you think about sort of where we've evolved the process of documenting and how, as I mentioned earlier, it lends itself to be a legal document. It's also meant for billing and all of that. But the ideal space, really putting on my physician hat and the pursuit of humanizing healthcare, the ideal space for that record really is for it to be a living, breathing document, right? For it to be a document that becomes a substrate for us to have that conversation, but also where we keep on adding things. We have the care team and the collaborators adding to the richness of that document that speaks to the patient's story throughout that journey. And I think we're getting there, but you can't get there without first opening the document up.
Yes.
Has there been any work with AI or speech in order to, one, get context of the patient and all the screening they may or may not have had, and then do a interactive engagement with the patient to still allow the patient to tell the story, but also be the decision kind of intelligence behind the scenes?
So I can speak to a little bit of this, and feel free to add to this as well. So what's really interesting about this conversation that we're having is that this is unlike any other conversation that you'll probably hear in most healthcare summits or conferences across the board. This is not about an expensive next generation tech stack with cloud-based tools, machine learning, AI. This is about simple. To our earlier conversation in a panel discussion, this is about simple. This is about culture change. This is about things that you can turn on almost immediately and have really lasting impact. Having said that, your question about AI is a really good one, because I think there are real opportunities for us to bring the elements of turning on the notes, making it open, enabling the culture change, but then leveraging these sort of the next generation of technologies and fronts to aid in streamlining our workflows. So one of the things that I've been involved in is to leverage AI to better the documentation process altogether, right? So this notion of, an example of this is conversational documentation, where we're not spending much of our time actually documenting. In fact, in the pilot that we've done working on this AI-generated conversational documentation UI, the user interface, so I call it the UI of AI, was really around saying, hey, let's not document anything while the patient is in the room. Let's have the AI algorithms actually listen in with the patient's permission to the conversation that we're having. And we're able to finesse it to a point where, depending on the circumstance, anywhere from 70 to 80, sometimes 90% of the documentation was complete by the time we were done with that encounter. And we would just have to go back in and add and correct and a number of other things as well. So there are lots of things that I think are developing in the space of voice. But back to my original premise, this is about low tech and simple. But I think high tech and complex and advanced can add and augment these simplistic things that we're turning on.
I have a question actually for the audience, just out of curiosity, everybody in the room, how many of you heard of this concept of OpenNotes before today? Okay, everybody, cool. So Kate's a researcher, super smart lady, awesome. And sometimes I feel like I'm her enthusiasm translator because researchers will often go, well, we've heard according to the data, da, 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 da. And I'm like, 99% of patients who've been offered the chance to read their notes say, yes, I should have continued access to this. On average, patients continue to read their notes over and over again when they know that notes are a thing. That the patient population most likely to benefit are those we consider most vulnerable, those who are older, people who are chronically sick, people where English is not their first language, that in that visit, they're like, what are you saying right now? And are able to go home and talk with a family member who is better at speaking English, or care partners. They love reading their notes even more because they're concerned about the other person, and maybe they weren't in that visit, whether it's their children or it's an older parent. And so I think about this, like, again, low-tech solution that already exists. You don't have to pay any money to turn something on, and people feel engaged in their care. And if this was a drug that you could say, hey, this is the drug of patient engagement and it only costs $5, well, this costs nothing. And we talk about how do you get your patients engaged? Give us access to our own information. And I was just watching a panel or two ago, and somebody was talking about it's so important that we as hospitals and health systems invest in metrics and tools so we have information in order to make decisions. And when it comes to our health, we are forced to make decisions, and we need as much information as possible in order to make those informed decisions.
Well said. A couple more questions. Yes.
I'm curious as whether we've seen a change in the way the documentation is completed. I think that probably a lot of our organizations, certainly mine, has been guilty of doing lots and lots of what we call smart text, but macros, where one word or phrase becomes a paragraph, oftentimes for billing or legal purposes, often not terribly useful for understanding what's going on. And we're part of this too, but I haven't talked to our folks to know whether we have seen a change that notes are actually made.
So what we know, there's actually just a paper.
Here comes the researcher.
Oh, yeah, here comes the researcher. So I try to tamp down the nerd, but
I'll translate after.
It just pops to the surface. So there was just a paper that came out looking at this very thing in oncology, where they processed the notes, and what they found is that roughly half of the clinicians did change something about the way they were doing their notes. And of that group, half of them, the language became more complex, and the other half, the language became simpler. So it's tough to draw a conclusion from that. The firm conclusion that they did draw, though, was that chronically late documenters got faster. So they completed their documentation in a more timely way. Now, we know from the patient side that they're pretty forgiving, even of your templated notes that have stuff in there that you don't think is that useful. They're pretty forgiving about that. What they don't like is when the templated note says, complete physical exam, done. I did these 17 different things, and I talked for 15 minutes, and I counseled the patient, and the patient says, wait a second, I was in there for 5 minutes. And the person never put their hand on me. So some of the templating that I know happens for billing purposes, and then the clinician needs to go back and edit it or edit out the things that they didn't do, that's creating a problem for when the patient reads the notes, and then they say, wait a second, they didn't do that. And then then that's sort of there can be a breach of trust there. So some changes in documentation probably will need to happen at some point, but we're not seeing, most doctors say they haven't done a thing to change the way they do it.
Just from a best practice perspective, one of the things that we've been doing, and this is both at UPMC and also at Atrium Health, this thing called note bloat is a real thing, right? Just because that's how we've been trained, really, even as we go through our residency fellowship programs and we have new physicians come in, is copy pasting or copy forwarding, making sure that the note bloat thing is real, and it is dangerous. It is actually dangerous because in that bloat are hidden things that should really be accentuated. And so there's an overall program that we're putting in place to improve physician documentation behavior. But it jives really well with the OpenNotes movement, because what we're saying is we're improving the documentation and our habits in how we're documenting, not just because it's the better thing to do, but it's also the right thing to do by the patient. And they have their eyeballs now on those documents, on those notes. So the copy pasting, copy forwarding is actually decreasing as a result of us putting those two initiatives together, and the quality of the documentation is actually improving. What's really interesting is that CMS is listening to all of this as well, and there specific legislature that's coming out, rulings that are coming out and encouraging us to actually document right versus perpetuate the note bloat reality of healthcare.
Did you want to translate?
I'm looking at Kate as far as the policy side and what you're seeing there.
Yeah, so speaking of CMS, there is a lot of policy activity right now, specifically around transparency too. So
Just make sure it doesn't tie into conditions of participation.
So this is likely coming at a broader policy level. Recently, ONC and CMS issued a notice of proposed rulemaking that requires notes be part of the uniform data set for interoperability. So that's coming. The 21st Century Cures Act actually makes it the law of the land that patients need to have access to all of the information in their electronic health record without, I learned that this phrase is very important, without special effort. So they should
in a machine-readable format.
Yeah, in a machine-readable format.
That's the other federal phrase.
So there's a lot of activity around transparency, both on the pricing. We've heard a lot about on the pricing side, but also on the information side. So I would expect in the next couple of years that this is something that CMS is going to essentially say you have to do it.
Yeah. Well, hopefully. You experienced what I did at South by Southwest, which is, wow, this is amazing. Last piece, you got 10 seconds each. You got a bunch of leaders in here. What should we do to continue the movement?
Good implementation. Get the patients actually reading the notes, because otherwise you've spent all this political capital to get the notes open. You got your providers upset about it. But if you don't, but the benefit comes when the patients are reading the notes. So you want to get to that point.
In this brave new world of value-based healthcare, open is the new currency. And that's the angle that we're really pushing forward with, right? So open is the new currency. So how do we make sure that this empowers our patients to take charge of their health, work with us, and not just take direction from us? So that's what I'd encourage you to really push forward with.
All right, it's the last song. Go ahead, Liz.
Oh my gosh, I'm the closer on this show. I'd say, so OpenNotes is not a health IT project. You can easily do this, work with your folks. This is not health IT. This does not cost money. This is a change management project. You're looking for simple solutions for innovation. This is something you could do right now. You do want to do it right and make sure patients know about it, but one step at a time. And if you're looking for that, spark of innovation for patient engagement, what is that secret sauce to do that? This is a way to get there. And if this was a drug, people would put commercials during the Super Bowl in order to get people aware of, go read your notes and really get engaged. So.
Perfect. Please, thanks the panelists.
Thank you.
You've been listening to a discussion of OpenNotes, a spreading model of care that encourages patients to read up and speak up about their own care decisions. This has been Advancing Health, a podcast brought to you by the American Hospital Association.